So imagine surviving a really grueling, terrifying battle with breast cancer. You've endured the surgeries, the chemotherapy, just the endless waiting.
Right, the absolute hardest parts.
Yeah. And you finally get to ring the bell, you're a survivor. But then you step back into your normal life and you discover this really cruel, unspoken reality.
Which is that the very treatments that saved your life are now making your daily life excruciatingly painful.
Exactly. The medications keeping the cancer at bay are also systematically breaking down the tissues in your own body. It makes things like, sitting, exercising, or intimacy just agonizing.
It's a profoundly isolating experience for millions of women. I mean, the narrative is usually focused entirely on eradicating the tumor, which obviously is the priority.
Right.
But the survivorship phase brings a completely different set of chronic physical traumas, and honestly, the medical system often treats them as an afterthought.
Well, welcome to another deep dive. Today we're opening up a massive stack of medical guidelines, clinical trials, FDA warnings, and clinic protocols.
We really are.
Yeah, we're looking at a highly specific, deeply misunderstood chapter of cancer survivorship. We're talking about restoring vaginal health after breast cancer.
Specifically, we're looking at the intense debate between two major therapies, local estrogen therapy on one hand, and these $1,000 laser tightening treatments on the other.
Right. And our mission today, based on all the sources we've gathered, is to explore the cutting-edge intersection of these two treatments. We want to answer one critical question for you. Is local estrogen actually needed before getting vaginal tightening treatments in cancer survivors?
And we are going to look purely at the biological mechanisms and the clinical data here. The marketing around vaginal rejuvenation is everywhere right now, and it makes some very bold promises.
Very bold.
Yeah. So our goal is to just cut through that noise and look at what the science actually demonstrates.
So let's unpack the core problem first. Surviving the cancer is the primary goal, but it seems like once that finish line is crossed, patients are hit with this completely new physiological crisis. Why is the aftermath so severe?
Well, to understand the aftermath, we really have to look at the collateral damage of the cure itself. For many women, the therapies that keep breast cancer from returning, like chemotherapy or endocrine therapies, they work by intentionally starving the body of hormones.
Right, because if the original breast cancer was hormone receptor positive, meaning it basically used estrogen as fuel to grow doer.
Exactly. The oncology strategy is to ruthlessly eliminate estrogen from the patient's system.
You just cut the fuel supply to the tumor.
Yes. But, estrogen is not just fuel for tumors. It's a fundamental building block for the entire female reproductive and urinary tract.
Oh, wow. Okay.
Yeah, so when you systematically strip it away, patients develop something called genitourinary syndrome of menopause, or GSM.
GSM. Got it.
Yeah.
I think the older medical term for this in our sources was vulvovaginal atrophy, right?
That's right. The tissues of the vulva, the vagina, and the urinary tract are highly regulated by estrogen receptors. Without that hormone, the architecture of the tissue literally begins to collapse.
Okay, wait. When you say collapse, what is actually happening on a cellular level? Is it just like drying out?
It's much more destructive than simply losing moisture. Estrogen acts like, well, think of it like the manager of a bustling factory.
Okay.
It tells the body to keep sending blood flow to the area. It maintains a thick protective lining of cells, and it keeps the tissue elastic.
So when the manager leaves,
The whole system shuts down. The blood vessels shrink. The vaginal lining thins out from a really robust multi-layer defense down to just a few fragile layers of cells.
yikes.
Yeah, the tissue loses its elasticity and its natural lubrication. And furthermore, the local pH level spikes, which actually kills off the healthy, protective lactobacillus bacteria.
So if we use an analogy here, it's not just like a sponge drying out on the counter. It's more like pulling the structural steel scaffolding out of a building.
Yeah.
The whole foundation becomes brittle and unstable.
That captures the structural failure perfectly. The tissue becomes incredibly fragile. Because of this, women experience severe burning, itching, and a condition known medically as dyspareunia.
Which is severe pain during intercourse, right?
Yes. The friction on tissue that thin can cause microtears and bleeding. On top of that, because the urinary tract shares these same estrogen receptors, women become highly susceptible to chronic recurrent urinary tract infections, as well as urinary urgency.
That sounds just unbearable. And I know natural menopause causes a drop in estrogen too, but from what I'm reading in our sources, this is very different for cancer survivors.
It is. The velocity of the change is what makes it so traumatic. In natural menopause, the ovaries slowly decrease estrogen production over several years, giving the body some time to adapt.
Right, a gradual phase out.
But for a breast cancer survivor, chemotherapy or hormone-blocking drugs can plummet estrogen levels to zero almost overnight. The onset of GSM is abrupt, and the symptoms are significantly more severe.
It's the ultimate paradox. The treatment that buys you more years on this earth makes those years incredibly difficult to enjoy. I mean, this affects sleep, mental health, relationships, everything.
Absolutely everything.
So when a patient brings this up to their doctor, what's the immediate medical response?
Well, the initial protocol is always non-hormonal. Doctors will recommend the regular, consistent use of over-the-counter vaginal moisturizers to replenish water content in the tissue and lubricants during intimacy to reduce friction.
But for a massive portion of women, particularly those with severe medically induced GSM, surface level moisture just isn't enough, is it, to repair that collapsed scaffolding we talked about?
No, it's not, which makes sense because you aren't fixing the missing estrogen, you're just adding water to a broken system.
So if the non-hormonal options fail, what comes next?
In the broader medical world, for patients without a history of cancer, the gold standard treatment is low-dose vaginal estrogen. This comes in creams, small inserts, or flexible rings placed locally inside the body.
Wait, let me stop you right there. Because if the entire point of the grueling cancer treatment was to hunt down and eliminate every trace of estrogen in the body to prevent a recurrence, how can an oncologist possibly hand that patient a tube of estrogen? Doesn't that contradict the entire cancer treatment plan?
The fear you're describing is incredibly common and honestly entirely valid. But we have to distinguish between systemic therapy and local therapy.
Okay, what's the difference?
Systemic hormone replacement therapy, like an estrogen patch or a pill that circulates the hormone through the entire bloodstream, that is generally contraindicated for breast cancer survivors.
That makes sense.
But vaginal estrogen is a localized, ultra-low dose treatment. The intention is to apply just enough hormone to restore the vaginal tissue with the assumption that minimal amounts will absorb into the systemic bloodstream.
But assumptions aren't enough when we're talking about cancer returning. Do we have hard proof that putting estrogen into the local tissue doesn't wake up dormant cancer cells elsewhere in the body?
We do. The medical community has studied this extensively, and the largest data sets we have are actually highly reassuring.
Like what?
For instance, a recent cohort study from Johns Hopkins analyzed claims data for over 42,000 breast cancer survivors suffering from GSM.
Wow, 42,000, that's a massive sample size.
It is. And the researchers found that using low-dose vaginal estrogen did not increase the risk of breast cancer recurrence. They also tracked overall survival and found no association with higher all-cause mortality at the 5 and 10-year marks.
Okay, that's huge.
Yeah, and that finding was echoed by another massive study. This one was published in 2024 in the journal JAMA Oncology. They looked at nearly 50,000 women and, again, demonstrated no evidence of an increase in early breast cancer-specific mortality associated with vaginal estrogen therapy.
Okay, so if we have nearly 100,000 data points saying this localized treatment doesn't kill you, why is this still a debate? Why are patients desperate looking for $1,000 alternative treatments if the gold standard is proven safe?
Because in oncology, the specific type of medication a survivor is taking changes the rules entirely. Our sources highlight a critical observational study out of Denmark that really complicates the reassuring data.
Uh-oh. What did the Danish study find?
Well, researchers found a potential increase in breast cancer recurrence specifically for a subset of women. It was the women who were taking a class of drugs called aromatase inhibitors while simultaneously using vaginal estrogen.
Let's break that down for the listener. Why would that specific drug make such a difference?
It comes down to how different drugs fight cancer. Many survivors take tamoxifen. Tamoxifen works by sitting on the estrogen receptor. Think of it like putting a broken key into a lock.
So the lock is jammed, meaning real estrogen can't get in to fuel the cell.
Exactly. Because the receptor is blocked, a tiny bit of estrogen floating by in the blood isn't a massive threat.
So tamoxifen acts like a shield. What do aromatase inhibitors do?
Aromatase inhibitors operate entirely differently. They don't block the receptors. They completely shut down the body's ability to manufacture estrogen in peripheral tissues like fat and muscle.
Oh, I see.
Their goal is to drive the total amount of estrogen in the blood down to absolute zero. So, for a patient on an aromatase inhibitor, even the microscopic fractional amount of estrogen that might cross from the vaginal wall into the bloodstream from a local cream, it's seen as a profound, unacceptable risk by many oncologists.
Wow. So for the women on those specific drugs, local estrogen is basically treated like a chemical minefield.
Precisely. It creates an agonizing clinical dilemma. Some oncologists will actually suggest switching a patient off a highly effective aromatase inhibitor and putting them on tamoxifen solely so they can safely prescribe vaginal estrogen to treat the pain.
That's a huge trade-off.
It is. And understandably, the fear of changing a life-saving cancer regimen drives a huge number of women to seek out powerful, non-hormonal alternatives.
Which leads us to the mechanical solutions.
Yeah.
If you can't use hormones to rebuild the tissue, you look for a way to force the body to rebuild itself. This is where we see the massive rise in energy-based devices.
Right. What clinics market as non-surgical vaginal rejuvenation? We are talking about lasers.
Laser.
Yes. The primary technologies being heavily marketed to these survivors are fractional CO2 lasers, erbium YAG lasers, and radiofrequency devices.
I have to admit the concept sounds wild to me. If a patient is dealing with tissue that is already profoundly thin, fragile, and prone to burning, how does firing a laser into the vaginal canal possibly help?
It sounds totally counterintuitive.
Yeah. Doesn't that just cause more damage?
Well, you're getting at the biological core of how these devices actually function. The entire premise is built on the concept of controlled damage.
Control damage.
Yes. These lasers emit tiny fractionated pulses of thermal energy, basically, heat that penetrate the upper layers of the vaginal wall. They deliberately create microscopic thermal injuries in the tissue.
So you are intentionally wounding an already compromised area.
Yes, but it is a microscopic wound designed to trick the nervous system. When the body detects those tiny thermal burns, it initiates a massive wound healing cascade. It rushes blood flow to the area. And most importantly, it stimulates cells called fibroblasts. These fibroblasts are responsible for a process called neocollagenesis,
Which is what exactly?
the rapid production of brand new collagen and elastin fibers to repair the quote-unquote injury.
I think I get it. To go back to our earlier structural analogy, if the estrogen was the manager that kept the factory running, well, the factory's been closed down.
Right.
The laser acts like a fire alarm, causes a panic, forcing the body to suddenly hire emergency workers to rebuild the structural scaffolding.
That is a brilliant way to conceptualize it. The procedure forces a mechanical rebuilding of the tissue without introducing any hormones. The treatments are quick, usually an in-office procedure taking about 15 minutes.
And how many do you need?
Typically, they require a series of 3 sessions spaced a few weeks apart. Radiofrequency devices work on a very similar principle, using a gentle, deeper heat to trigger that same fibroblast response without ablating or cutting the surface layer.
It sounds like a miracle for someone who can't take estrogen. But, reading through the FDA documents in our sources, it seems the federal government does not share that enthusiasm.
Not at all. The regulatory environment around this is incredibly tense. In 2018, the FDA issued a stark public safety communication directly targeting the deceptive marketing of vaginal rejuvenation.
What did they say?
They clarified that while these laser devices are officially cleared by the FDA for general surgical applications like cutting or vaporizing abnormal tissue, they have never been specifically approved for treating genitourinary syndrome of menopause or for sexual pain.
So clinics are basically using a surgical cutting tool off-label to treat menopause symptoms.
Exactly. The FDA explicitly warned that the safety and effectiveness for this specific use had not been established, and they cautioned patients about severe potential risks.
Like what kind of risks?
Deep burns, permanent scarring, and persistent pain.
Wow. But despite the warning, women are still paying thousands of dollars out of pocket for this. So putting the marketing aside, do the clinical trials show that the fire alarm method actually works for breast cancer survivors?
The evidence is a bit of a roller coaster, honestly. Early retrospective studies were incredibly promising. They showed patient satisfaction rates up to 84%, with massive reported relief from painful intercourse and severe dryness.
That's pretty high.
Yeah, some studies even documented that the vaginal pH decreased back to healthy premenopausal levels.
But retrospective studies just look back at past data, right? What happens when you put these lasers to a rigorous controlled test?
That is where the narrative hits a major speed bump. The clinical trials introduce a massive curveball, most notably a landmark study known as the LIGHT trial.
Okay, tell me of the light trial.
It was a randomized trial published in the journal JAMA Network Open, and it specifically looked at breast cancer survivors taking aromatase inhibitors. This is the exact demographic most desperate for a non-hormonal laser treatment.
So how did they set up the test?
They took a group of these women and divided them. Half received the actual fractional CO2 laser treatment. The other half received a sham treatment,
A fake laser.
a completely fake procedure. The doctors inserted the device. The machine made all the same humming and beeping noises, but no thermal energy was actually emitted. No micro-injuries were created.
And the results. Did the real laser rebuild the scaffolding?
While both groups showed significant improvement in their symptoms.
Wait, both groups?
Yes, but the trial revealed that the actual thermal laser treatment was no more effective at reducing symptom severity than the fake placebo laser.
Wait, I just want to make sure I'm hearing this right. The women who just sat in a room with a buzzing machine felt exactly the same amount of physical relief as the women who had their tissue microablated.
They did. The sham laser performed just as well as the real laser in reducing the pain of intercourse and overall vaginal severity scores.
That is mind-blowing.
It completely disrupted the assumption that the thermal injury was the sole magical driver of the healing. It raises massive, complicated questions about how we measure the efficacy of these devices.
Yeah, no kidding.
And it brings the powerful phenomenon of the placebo effect into sharp focus, which is something we will touch on again.
Okay, so if the standalone laser results are that muddy, it brings us right to the absolute core focus of our deep dive today. Let's intersect these two worlds.
Let's do it.
We've established that the laser tries to trigger a wound healing response by waking up fibroblasts. But if a cancer survivor has been utterly depleted of estrogen for years, those fibroblasts basically starved. The factory is empty.
Right.
Does the laser actually need some estrogen fuel in the system to work properly?
It is the most critical biological question in this entire landscape. If your cellular machinery is dormant because of profound estrogen deprivation, how robustly can it respond to a thermal fire alarm?
Right.
Can it actually build healthy collagen, or does it just create disorganized scar tissue?
If you try to laser tissue that has zero underlying health, would it just burn without healing? Do you need to prep the tissue with local estrogen before getting laser tightening to actually get the structural benefits?
Let's look at the clinical consensus. According to the American Urogynecologic Society, or AUGS, their official consensus statement indicates that pre-treating with estrogen is not an absolute medical requirement to undergo laser therapy.
Okay.
In fact, if you look at the strict methodology of many energy-based device trials, the researchers deliberately exclude any women who have used vaginal estrogen within the past month or two. They want to isolate the variables and test the mechanical laser entirely on its own.
So it isn't a hard requirement. You can undergo the procedure without it, but does the science show that adding estrogen makes the laser better?
It makes it significantly better. The evidence supporting synergistic therapy, or using both treatments as a tag team, is highly compelling.
Yeah.
When you prime the tissue with estrogen, you optimize the body's ability to execute that wound healing cascade.
What kind of proof do we have for that synergy?
Our sources detail a few pivotal trials. One study looked at postmenopausal women who were pre-treated with something called estriol. Estriol is a very weak, naturally occurring estrogen.
Okay.
The women used this estriol treatment for 2 full weeks before undergoing erbium YAG laser therapy.
So they woke up the factory workers before pulling the fire alarm.
Precisely. And the researchers found that the combination group experienced a much greater reduction in all GSM symptoms compared to women who solely used the estrogen cream.
Wow.
Even more importantly, those improvements in elasticity and pain reduction were more pronounced and lasted significantly longer at both the 12-month and 18-month follow-ups.
So prepping the tissue gave the laser a foundation to work with, resulting in a much more durable repair.
And there's more. Another randomized controlled trial compared a combination of a CO2 laser plus an estrogen cream against a laser plus a placebo cream. Over a 20-week period, the combination group showed vastly superior improvement in symptom relief compared to either treatment acting entirely alone.
That's fascinating.
The clinical data strongly suggests that the thermal injury of the laser and the cellular fuel of the estrogen work together to create an optimal healing environment.
But think about the absolute paradox this creates for the listener, the breast cancer survivor. The ultimate irony here is staggering.
It is a profound clinical catch-22.
The entire reason a breast cancer survivor is researching these out-of-pocket FDA-warned lasers in the first place is because they are terrified of or clinically barred from using estrogen.
Exactly.
They're desperately seeking an escape from hormones. But the deepest scientific evidence suggests that to get the absolute best, longest-lasting structural results from that laser, you actually need to prime your tissue with the exact hormone you are running away from.
It places the survivor right back at square one, standing at the door of their oncologist's office. It means they still have to navigate the nuanced, highly specific safety profiles of local estrogen.
Which is so tough.
Yeah. If a patient is on an aromatase inhibitor, and their oncology team determines that absolutely no estrogen can be introduced, the laser might still offer them some localized benefit, as we saw in the retrospective data. But they have to go in knowing it might not deliver the optimal, long-lasting tissue restoration they are hoping for without that hormonal primer.
So to synthesize this journey based on our sources, we set out to ask if local estrogen is needed before getting vaginal tightening treatments. And our sources suggest that while it is not strictly required by medical guidelines to undergo the procedure, the biological evidence strongly points to a massive synergy.
Right.
Using them together offers the most robust tissue restoration.
But because energy-based devices still lack long-term, standardized medical protocols, and because estrogen carries such deeply individualized risks depending on the specific pathology of a survivor's cancer and their current medications, this cannot be a decision made lightly.
No, absolutely not.
It cannot be based on a pamphlet in a Metaspanning waiting room. Every single step must be a deeply personalized, rigorous conversation with an oncology team.
It's just an agonizing balancing act between preventing the recurrence of a deadly disease and fighting for the fundamental right to live the rest of your life without chronic pain.
It is. And before we close out this deep dive, I want to leave you with one final concept to mull over, returning to a mystery we uncovered earlier. Let's think back to the Light trial, the rigorous study where the sham fake laser performed just as well as the real tissue-burning laser for women on aromatase inhibitors.
Right, the placebo effect that matched the million-dollar technology.
Think about what actually happened to the women in both groups of that trial. Whether they got the real laser or the fake one, every single woman was required to follow a strict protocol. They had to use a vaginal moisturizer consistently for 5 days before and 5 days after the procedure.
Okay, so a lot of hydration.
Yes. They both received topical numbing creams. But most importantly, both groups had a dedicated team of medical professionals intensely focusing on their pelvic floor health, validating their sexual pain, and providing hands-on care.
Which is something most of these women had probably never experienced in their survivorship journey.
Exactly. So the provocative question the data leaves us with is this. Could it be that the simple, revolutionary act of a doctor finally taking a woman's sexual pain seriously, enforcing a consistent internal moisturizer routine, and providing attentive, dedicated pelvic care is powerful enough to trigger profound physical healing on its own without a laser ever being fired?
That is a phenomenal question. It reveals just how much the medical community still has to learn about the intersection of physical trauma, the nervous system, and the environment of healing. Thank you for joining us on this deep dive. We started by looking at tissue that had its structural scaffolding ripped away, and we found that while there are mechanical and chemical ways to try and rebuild it, the biology is incredibly complex and deeply personal. Keep questioning the easy answers, keep investigating the nuances of your own body, and above all, keep advocating for your own health and comfort. We will catch you on the next deep dive.